So among the various issues that came up, particularly last spring and into the summer with COVID, among the many, many issues that came up were what happens to the patient voice, particularly as we began to talk about not just shared decision-making, but about triage decision-making, crisis standards of care, that we were creeping closer to where is the patient's voice in that, and how do our ethical standards, particularly those who are very focused on shared decision-making, how does that shift when there are crisis standards of care or when triage decisions are needing to be made? So we have three fabulous people here to speak with us about approaches to that came up last spring, as well as things that we're continuing to think about and talk about in terms of bringing the patient's voice into triage decision-making, alongside of policy issues, as we spoke about last month, alongside of vaccine issues that we'll speak about next month. This is about the patient's voice and what happens with shared decision-making in these kinds of circumstances. So I want to introduce you to three people who are going to present, and then we'll be glad to take questions. The first is Dr. Dan Matlock. Dan is the Associate Professor of Medicine and Director of the Accords Program for Patient-Centered Decisions. Then Dr. Sarguni Singh, Assistant Professor in the Division of Hospital Medicine in the Department of Medicine here at University of Colorado Hospital and School of Medicine. And Katie Herrmann, who is the Manager of Inpatient Social Work Services at University of Colorado Hospital. So thank you, all three of you, for guiding us in this. You each get 2 minutes of uninterrupted time. I'm just kidding. But first, Dan, we'll turn to you, and thank you very much.
Thanks. Hopefully during this 2 minutes, I won't get interrupted more than 3 or 4 times. So, yeah, thanks. And thanks for having this idea to bring this story to Ethics Grand Rounds, Dr. Swaney. I think it is a bit of a story that we're going to tell and how it's going to come through. But the title, Bringing the Patient's Voice into Triage Decision-Making. And like Dr. Swaney mentioned, there's lots of things we could talk about in this space, but what we kind of came together to talk about is a story of how we actually tried it. So this talk will somewhere bridge this sort of ethical, how do we do this, with the implementation challenges and barriers of actually doing it in real time. And hopefully that story will be interesting and informative. But I'm going to talk a little bit about the importance of the patient's voice in allocation decisions, and then talk about one attempt that we made in a very short period of time to try and make a decision tool for patients to do that. Then Sarguni is going to talk about her experience of actually trying to do it, and a little pilot trial that we ran that had mixed success, I would say, and talk about why that was. And then Kathleen Herrmann will talk at the end about what I think is a bit of a success story about how using healthcare agents and through medical power of attorneys in the inpatient setting. But just in, trying to put people back into March and April of just how anxious we all were, and how we didn't know what was coming, and how we saw this shape of a curve and everything was pointing up. And we didn't know where it was going, and we saw lines of ambulances outside hospitals. I mean, just everybody put yourself in that context, because that's the context when we were having these discussions and thinking about this. So our team has purchased the rights to show this cartoon because I really love it. I lead the program in patient-centered decisions, and we do research in shared decision-making. And this is what a lot of people think of as shared decision-making, is you just throw options at a patient and then let them decide. And we really try not to do that. There's really nothing shared about that, but it's a good cartoon, and it makes the point that that can be very concerning and even burdensome. And this theme will come up a little bit later about how throwing options at a patient could potentially be burdensome. And so we want to talk about that. But there's lots of definitions, and there's some very formal and wonky definitions of shared decision-making. But this is my favorite, a meeting between experts. It comes from a book in 1985, before this was even really a term. And I just really like it because it acknowledges the shared expertise. You have the expertise of the clinicians, the expertise of the patients and their own values and goals and preferences. And if you bring those together, then you're sharing a decision. And if you go too far one way, you have that familiar model of paternalism that medicine is famous for. But if you go the other way, if you let the pendulum go too far, you have this consumerism. And Timothy Quill, actually, in an article he wrote in Annals of Internal Medicine several years ago, actually called that a form of patient abandonment. Just throwing options at patients and letting them decide on their own is not really sharing anything with them. It's just kind of putting all the burden on them. And our culture, at least in United States medicine and much of Western medicine, is there's 100 years of court cases, starting with, I think, Mary Schlendorf in like 1910, that have continually reaffirmed a patient's right to choose their course of care. And as you get into advanced care planning and end-of-life decisions, there's some famous cases, Karen Ann Quinlan in 1976, where the New Jersey Supreme Court ruled in favor of her parents, and she was able to be taken off of life support. But at that time, artificial nutrition was continued for 9 more years. And then in 1990, with Nancy Cruzan, came the decision around artificial nutrition and hydration. And there, the Supreme Court said that the administration of artificial nutrition and hydration without consent is an intrusion on personal liberty. And then this kind of all became codified in 1990 in the Patient Self-Determination Act, which basically said that as patients are admitted to any sort of healthcare facility, they have decision-making rights. And this act gave some policies regarding advanced directives that patients have the right to facilitate their own healthcare decisions, the right to accept or refuse medical treatment, and the right to make an advanced healthcare directive. And then facilities must ask if the patient has a healthcare directive. Facilities must provide education to their staff about this, and healthcare providers can't discriminate based on advanced directives. There's lots of data that patients want to talk about this, and that they want their doctors to bring it up. And there's data that doctors often have no idea when their patients have an advanced directive or what it says. This is older data. It's 2003. I think this is quite a bit better now, but it makes the point that we often don't have a great idea of what the patient's preferences are. So, we have this culture in this country where this ethic of patient-centeredness and patient autonomy is often prioritized above other ethical issues. And then you get to March, when you get into this place where we had this fear that we were going to run out of ventilators and run out of dialysis machines. And I actually think, I don't know where we actually got with that, but fear of running out of even medicines to sedate people. I know that was one of the things that we got the closest to if we didn't even get there, so that just intensive resources that were scarce. And if you get to a place of scarcity, this 100-year ideal of patient-centeredness and patient autonomy will get a little bit trumped. If you can't do patient-centered decision-making if the things that they're making decisions about are not even an option. And so it's this sort of shift from a patient-centered ethic to a community-centered ethic. And this is a gross oversimplification of the nuances here. The community-centered ethic is sort of always at play, and the patient-centered ethic is always at play. But when scarcity comes, there's definitely a shift. And that's what we were thinking about with these crisis standards of care and rules for allocating ventilators, and how do we choose who gets ventilators, and that's because of scarcity that we get put in that place. So how, then that's where this discussion came along of how do you bring the patient's voice into these decisions in a time of scarcity? So that's the question. How do we compassionately and respectfully ask people about decisions that are really tough, like whether they would be willing to give up a chance of being on a ventilator if there were an absolute shortage? So in March, Matt Winnie approached our team and said, we ought to make a decision tool or decision aid that gets into this. And so it was actually, I think fun is the wrong word, but energizing. It was an energizing process. We had a team of people, 40 or 50 people that ended up giving input on this, coming together and talking about, we made a one-page thing that we envisioned a hospital or a system could hand to a patient or family when they're coming in to try and get their preferences, both acknowledging that your preferences are important here, and we may get to a point where we don't have enough ventilators where you don't even get to make a decision. Where this is generally something you would, prior to this scarcity or this pandemic, your preferences would have driven this decision making. And so we spent a long time, and in my experience making decision aids and patient facing tools, it's just a lot of iteration. We went through Rosa, one of the research assistants in the ethics department, really helped with this. We went through about 14 or 15 versions over 3 or 4 weeks. We were iterating this every 2 days based on feedback, trying to get this language right. And here's just some of the language we came up with. This is an unusual time with very large numbers of very sick people. Some people are getting so sick they might need a life support machine. And just trying to get this where we introduce this and introduce the emotional language and try and do this in a gentle way that's not too scary. And then acknowledge that there's scarcity, and this is what we came up with. And then we ended up with this question. And this is I think there's a lot of ethical issues that this question raises. And we'll talk about that a little more too. And in the discussion part, I would love to talk about that as well. But we asked on this paper, if you became sick enough to need a life support machine, would you want? And the first choice was, what would you want? I would want the life support machine if the machine is available. I want one if it is available, but first consider others who may be more likely to survive. I understand this would mean that I am more likely to die. And then I don't want one, even if it is available. I understand this would mean that I am more likely to die. And then, some of the people, especially one of the psychologists I work with, said, you really need to ask a second question, really verifying that this is what they want. So we asked a second question: are you sure your answer above says what you really want? Yes, I understand this, or no, I don't. And you can look at this and you can see the challenges here immediately. That this could potentially be coercive. Yes, it brings the patient's voice in, but at what cost? So we actually made this tool available on our website because there were other cities and places in a worse place than we were. And in March and April and May, we had several hundred people download this tool around the country. And we also made it available in Word, which is not something we do with our other tools, and said, you guys are free to edit this if you want, if you have better language. Usually if I make a tool, especially one with this many ethical issues, I'd want to study it in a trial and really measure some outcomes to really find out how people are interpreting it. We did have patient input. My team has a patient panel that we run over at Accords. They're actually meeting right now. And they gave input on this tool, and they had some concerns about it too. They said, yeah, you should do this, you should ask this, but wow, would I feel coerced to pick that middle option, even if it wasn't what I want? I'm not sure. So that gets into, and this is still on our website, it's still available if people want to download and look at the whole thing. But there were lots of challenges and tensions that came up. We want to give people the opportunity to state their wish and say, yeah, I want a ventilator. I'm not DNR, but if you run out of ventilators, I'd rather you give it to somebody else. Like, that's what my father said. I had him look at it. He's like, oh yeah, this is easy. I would want the middle one. Yeah, I'd want a ventilator, but I don't want one if there's some younger person who could have it, is what his direct quote. Another colleague, one of the clinical colleagues said, this is like one of those trick questions where the people that we should save with ventilators are the people who are the ones that are willing to sacrifice. He was joking, but he made a good point that, it is kind of interesting. So there's this, you don't want to coerce or guilt or put too much pressure on a person while we're trying to get their voice involved. We also don't want to use a ventilator on somebody who says, why did you give this to me? I would have much rather you done this for somebody else. And then the other issue that came up that I'm going to turn this over to Sarguni, she was really helpful in thinking through this and actually just highlighting how difficult this is and was going to be is, how do you implement this? So yeah, we have this piece of paper. We had some people on our team saying we should give this to everybody in the ER who comes in short of breath, or we should give it to everybody in the ER, or we should only give it to people when they're coming to the ICU. So there's that issue, and that comes up in all of our trials of using decision tools, is when do you give it to somebody? We weren't, and we never really did hit that scarcity point, but we were wondering if we would. So do we start using it now, or do we really wait until we've hit scarcity and have those crisis standards of care come into play? And those are all the things. And then if you give this to somebody, can you just give it to them and then let them read it and then come back later? Or is this such a sensitive topic that someone needs to take their time and sit down with them? And then how do you do that when people aren't even allowed in the room and nobody really has time and the hospital has this fear of being overwhelmed? And so there's all kinds of implementation challenges. But this was, I think, our first attempt at trying to do something, not knowing what was coming. So with that, I'm going to unmute myself and turn it over to Sarguni. I'll continue to advance the slides. So just tell me next slide when you're ready, Sarguni. And
all right. Thanks, Dan. My name is Sarguni. I'm one of the internal medicine docs here. I work at the University of Colorado Hospital as a hospitalist. And my role in this work was essentially to pilot this decision aid to see how do patients respond to this and what is kind of the feedback that we get from this. So what I did was I went and I asked my hospitalist colleagues who were working on service to give me a list of patients who were knowledgeable enough, who could help me weigh in, who they thought were medically stable enough that this wouldn't scare them. And so what I did was I picked 8 hospitalized floor patients. 2 of these patients were COVID patients, but they were close to, they were close to, start video. I'm sorry, I'm not sure if you can hear me. Anyway, so they were close to, a discharge. And essentially what I did was I gave patients this decision aid and I said, will you take a few minutes to look at this? Do you think this decision aid is helpful? Would you change or would you add anything to this decision aid? And do you have any other feedback? And 6 of the patients responded and they said, look, we understand what you're talking about. This is a tough topic to talk about, but it's clear and we understand it and here's the decision. One of the patients said that they would like a little bit more information about how long, if they needed a ventilator in the setting of COVID, that they would need to be on the ventilator. And I thought that was helpful for feedback for the decision aid. Probably the 2 most kind of interesting experiences were, one was a patient who probably had mild cognitive impairment, but it was kind of challenging to pick up. And so their interpretation of the decision aid was kind of filled with stress and anxiety, where they were saying, I thought I was leaving the hospital tomorrow. Do I now need a ventilator? Are we short on ventilators? And so it required me to spend probably 25 to 30 minutes with them, explaining kind of the current situation, that we're not at a scarcity point yet, but really just a lot of reassurance. And that was illustrative in terms of, if this decision aid is delivered and it causes more anxiety and stress, that it would take a lot of provider time to try to calm patients down. The most interesting conversation I had was with a probably 45-year-old cancer patient. And he was very thoughtful about his feedback to me. And what he said was, I understand why you have to do this, but with these options, you're essentially just asking for my preference and you're not asking my permission. And I thought that that was really touching, and I reflected on that a lot after our interaction, because it felt to me that our desire for transparency and our desire for, patient autonomy was also leading to patient distress. And he basically said, if this is a decision that you as a healthcare system have to make, you should keep that distress to yourself and don't put it on the patient. And so that the concept of you're asking for a preference and not a permission really stuck with me as I continued to pilot the decision aid. This was also echoed by my hospitalist colleagues. So I sent out a survey to them, about 15 of them, 11 of them responded. I think reassuringly, 8 out of 11 people said they would feel comfortable using the decision aid. And 6 of them thought it would be helpful. A lot of comments were also saying, hey, it seems like you're just kind of putting the pressure on the patient. And if they don't really have a decision, why would you kind of give them this option? Next slide, please. So this brings me to the operationalization challenges. And these were, and I put out a list of the questions that we really struggled through, and Dan kind of highlighted them a little bit. But the first question was, when do we start using the decision aid in the health system? Do we start it at a point when we are close to scarcity? How do we define that? Are we talking about scarcity of ventilators, dialysis machines, key medications? Or do we start it upstream when we're totally not even, close to scarcity, but that we have it integrated into our system and we know what patient wishes are? And I think that was a question that we didn't really come up with a clear answer to. The next big question was, who gets the decision aid? And I think when we were first creating this, the natural thought was, oh, well, all COVID patients will get the decision aid. But thinking that through a little bit, not everybody who's coming into the hospital and needs a life support machine will be coming in with COVID, and they would also be dealing with the repercussions of resource scarcity. The other thing that we were noticing is that the patients that were being admitted were of ethnic and racial minorities in our community. And this was early on in COVID. And so we didn't have the data that we have today showing the disproportionate effect that COVID had on these populations. So to then say, if we only give it to COVID patients and we're recognizing it's these minority groups, to then hand them a decision aid to say, well, only you have this dilemma of dealing with a resource shortage. How would you choose to proceed? Feels like it's perpetuating the discrimination that they've already experienced in our healthcare system. If you think about, well, do we do it with people who have low likelihood of surviving a long intubation with COVID? Those patients are usually older, have multiple comorbidities. And again, you kind of go down that same path where, are we being ageist by offering this to older patients? And, who knows the history behind why people have pre-existing conditions? Is it a result of, discrimination that they've experienced in the healthcare system earlier on in their life? And then the other question was, well, if we give it to everybody, there's people who come into the hospital overnight and they just need antibiotics for a day, or they come in for a urinary tract infection and they're 24-hour stays, they're very stable, and walking in and saying, here's the antibiotic I'm going to give you for your urinary tract infection. Oh, and also tell me what you'd want to do in the setting of this resource shortage feels really out of place. And I think it would lead to a lot of providers having to go back and reassure patients. And in a time where in a space where provider time is a really, really critical resource, going back into stable patients and reassuring them that nothing bad is going to happen is a really big, has a big implication for provider workflow. The other thing we thought about was, when during the hospitalization does the patient get this decision aid? So I I think ideally you'd want people to get it earlier in their hospital stay when they have the capacity to weigh in. Should something change in their medical course and they lose capacity, we have their wishes captured. So if you do it in the emergency room, what about those direct admissions from clinic? What about the outside hospital transfers that just hit the floor? How do we really capture all the patients that come into our hospital? The other thing that we really struggled with was like who actually completes the form with these patients. We talked to social work, care management, teams, and it's a really, really tough topic to talk about. You need to understand the patient's medical condition and understand kind of the landscape of where we are in terms of COVID and resource scarcity. So a lot of provider groups, nurses, social work, care management, hesitated in kind of taking ownership of this, very reasonably so because of the tough nature of these conversations. We thought about, giving it to people in their admission paperwork. They get this pamphlet. It doesn't feel like a thing that you would kind of slide under someone's door and say, hey, I'm going to come back and talk to you about this later. And then we certainly talked about, do the primary teams, do the provider teams, the MDs, the APPs who are on the service, have these discussions with patients. And certainly that seems like the most reasonable approach. I think the biggest limitation again is time. And the other issue that came up was, if I give this to a patient and I'm caring for them and they don't really know how to answer the question and they ask me, well, doctor, what do you think I should say? That puts me in a really tough position because when we think about distributing scarce resources, you really want the team that's making these decisions to be separate from the providers directly taking care of those patients. And so now if my patient is asking me, how do you think I should answer this? That will just add to my moral distress in a way, already feeling morally distressed. And so those are situations that could arise that we don't really know how to guide people on how to answer. And lastly, how do we document and track completion? So, if we get to a place where we want everyone in the hospital to have this, how do we upload this into Epic? We were worried that COVID was on surfaces. So how do you bring this paper in and outside of the room? How do we get providers to document this in their notes, and how do we keep them up to date? What if a patient refuses to fill out the form? How do we document like, oh, we talked to them about it, but they didn't fill it out today, so I'll circle back and fill it out tomorrow. So I think these questions should highlight just the operationalization challenges that this decision aid brought forward. And I think these were really tough questions that we really wrestled with, but they were really good exercise to kind of think through. Next slide, please. So I just like to close by thinking a little bit about implementation strategy. And one thing that I think would be really helpful if we have to do this again at some point or implement this is thinking a little bit about what are implementation strategies that have worked in the past. And there's something called the ERIC project, which is Expert Recommendations for Implementing Change. And it's a list of 73 essentially strategies to implement new novel ideas and efforts into a health system that was taken from various stakeholders, including leading implementation researchers in our health system. And one thing I think was missing was our engagement with our health system. And again, as Dan mentioned, the rapidity with which we were creating these decision aids, doing this pilot was over a span of a few weeks. So we missed the opportunity, I think, to conduct a local consensus discussion with our health system to say, look, we know that resource scarcity is important. Does this decision aid fit in as a solution that you think is a way to address it? We didn't have the chance to build a coalition, meaning partnering with health system leadership to say, hey, how can we work together to implement this effort? And I think what was really missing was a clear kind of declarative statement from the health system leadership to say, this decision aid is a priority and we are determined to implement it. And when I think back about the messages I got from COVID from the UC Health System, a lot of it was, make sure you have a code status discussion. Here's the situation on PPE. And we didn't have one saying, here's how we're going to handle the resource shortage. And I think the health system could have really helped us in terms of centralizing technical assistance, primarily with Epic, creating an implementation team that was in charge of implementing this in our health system. And then, staging this implementation, you could start it on a floor at University of Colorado Hospital and then go broadly at the hospital itself and then go to other sites in the system. So I like to reflect on looking back, now that we're not in the thick of it, what were the implementation strategies we were able to use versus what are the ones that we were missing that would be key to think about if we have to do this again in the future. And I'll turn it over now to Katie, who has I agree with Dan, a more successful story about when you can work with the health system in a way that does lead to great change.
Thanks, Sarguni. Hi, everybody. I'm Katie Herrmann, and I'm going to talk to you today about how the Care Management Department and Social Work stood up an emergent MDPOA process during COVID. It's important to note there was a process for advanced directives pre-COVID, but we found that for several years, we really had low numbers of completion and scanned into the system for the MDPOAs. And so we were already working on how do we improve and have the opportunity to improve these numbers, because it was really averaged about 26% during pre-COVID. So a small internal group of leadership was working on, what are the opportunities we have? How do we implement and get a better numbers for scanning and having advanced directives in the Epic chart? Now, that's pre-COVID. During COVID-19, what we were seeing were a lot of people coming into the hospital who did not have any advanced directives. And some of them were mildly sick, but some were really sick. And there was just there was a total sense of urgency throughout COVID, but there was a sense of urgency to get these folks an MDPOA in place before the patients became incapacitated or intubated and unable to make decisions for themselves. And a core component to social work's code of ethics, one of them is the person's right to self-determination. So this was really near and dear to our heart, to make sure that we were reaching patients and making sure that before they became so ill they couldn't make decisions, that we at least offered to help assist them with the MDPOA process. So in that, next slide, the process actually wasn't that hard to stand up, because our RN care managers actually screen every inpatient that comes into the hospital for care management, social work needs, discharge, disposition needs. So what we were able to do is, as a part of the RN care manager screening process, we would have them screen to see if advanced directives were in the chart. If advanced directives were not in the chart, or there were only verbal orders and verbal documentation in the chart, they would then put in a consult to social work, and social work would then go and meet with the patient, talk with them about the MDPOA process, and work with them to assist them in completing it. And then the social workers would make sure that those got scanned and put into the hospital chart. Next slide. So the implementation of it was easy. The challenges were, and I was quite surprised about this, I think this really highlighted for us that there is a huge opportunity for need to improve getting the patient's voice in here and getting the advanced directives filled out for these folks. We had a huge volume of requests. The first week of implementation, in second week of April, we implemented it. We had 167 social work consults just for MDPOAs. That's not counting any of the other social work consults we would get. So the first week we had 167. The second week we had 333 consults for the MDPOA. And again, that's just for MDPOA needs, not necessarily counting all the other social work needs we might also get consulted on. And then the third week was 303. So you can see there was a vast volume. What was shocking to me is like, wow, a lot of people don't have advanced directives, and that's an issue because, and I think COVID has highlighted so many things through this experience, but this was again kind of shocking. The challenges with this was unsustainable for our social workers to keep up with the demand for completing the MDPOAs, along with performing our normal social work duties and discharge planning. The other challenges is that during COVID, we unfortunately happened to be down 5 social work staff. So I had about 25 or so, 26 social workers who were working during COVID, and divvying all of these up between was quite a challenge. Shout out to our RN care managers, team members. They also jumped in. We would ask them if they could help us complete these MDPOAs, because we did all feel this sense of urgency to make sure as much as possible we could get the patient's voice out and heard during this, so when they became too ill to make decisions for themselves. So we did our best to get these done as best we could. But then in June, it really just became unsustainable. So what we did is we regrouped and met with Sarguni and some other providers and said, okay, this just isn't sustainable for us. We know the importance of this, but how do we make this work? And so what we did is we actually prioritized the high-risk acute care patients who were at the highest risk for decisional incapacity. That included, I'm probably not going to name all of the units, but obviously all the COVID surge units, they were an absolute priority to try to get these done. The ACE 1 and 2 units, our senior unit, and the medicine floors, and TACS, our trauma unit. So really have focused, and we're continuing this process. This didn't stop as the COVID numbers went down. We still get a high volume of consults for MDPOAs and continue to work on that throughout the hospital. So we didn't limit it to, but we didn't limit, getting an MDPOA consult. We get them from throughout the hospital, but our priority is on those higher risk units and patients. Next slide. And this last slide, I think here's the success story, and I am really proud. I think one of the things that astounds me is in situations like this, often we say, well, we're working on it, but then something like COVID hits, and it was amazing to me how quickly everybody just came together and stood up and got it done and did it. So it is from palliative care. They keep track of the MDPOAs, how many have been completed and scanned. And just to show you the numbers, we really, from January, February, March, you see that it was really only at 25% or less. And then in April, and again, we started this the second week of April, we jumped to 40.2%. In getting MDPOAs scanned and completed. And then in May, we also went 40, went up even a little higher. In June, it was in the beginning of June that we just started prioritizing those other units. So we dropped slightly, and as you can see, we dropped in July even more. And then in August, we bumped up, and part of that is I'm getting staffing up and all of that. But still, the 38%, it's not where we want it to be. I'd like it to be 100%. But if we can, we still have some opportunity to improve our rate of getting these MDPOA completed and scanned in the system. But I think it's much better than it had been over the years. So just really proud of everybody coming together and doing the right thing for our patients that we serve. And that's it. And we're going to move to questions now, I think, right, Dan?
Okay, thank you. Whoops.
Yeah, I think so.
There we go. Thank you very much, all three of you. Really appreciate that. And There are some questions that have come in and some comments, and so I will pose a few of these to you. The first one, and Sarguni, you made some reference to it, but Dan as well, in terms of the decision aid, the issue of vulnerable populations or the oppressed or people who may feel discriminated against, and how you might have worked with trust in terms of trust in the healthcare system, trust in supporting their autonomy, and yet having to set limits or having them set limits on it as well. Just wondered if that was anything that was part of your experience.
You mean, that's actually a tough question. You know, that's where, when I mentioned I would have loved to have like this is me as a researcher, run a trial and studied it. I mean, how great would it have been to measure trust? And, you know, there's this ongoing tension of, is this thing helpful or is it hurtful? At least for for the decision aid piece. And I actually think for some people it's helpful, and then maybe for some people it's hurtful. And then how do we distinguish like who that is, and how do we determine who those people would be? Because I could see it going both ways. I could see being really transparent about the challenges we're having, gendering trust.
Mm-hmm.
I could see the feeling that this decision is being dumped on me, hurting trust. And I actually don't know which way it would go, and that's part of the challenge of being in the situation of doing something so quickly without a lot of preparation is not really knowing what that outcome is. Because I think trust is one of those emerging and really important outcomes around shared decision making, and good shared decision making should engender trust. But I don't know if that answers your question, but those are the thoughts I had.
Yeah.
Yeah, I think, trust is something we struggle with regularly in the hospital setting. And there's certain, ethnic and minority groups who I know are very hard. The idea of a person in this group ever being DNR, DNI is just a no-go, because they don't trust us, and they don't trust that even if they say, I want to be do not resuscitate, that they would still get the same care as otherwise. And so I think that would be a really big challenge in some ways, because the decision aid is more just asking someone's preference as opposed to a final decision. It might leave room for a better discussion to say, hey, look, we just want to know your wishes if this situation arose, but we can't guarantee anything. But I think that would be a huge challenge. And I think that would, again, take a lot of time and reassurance to be at that bedside, when you're wearing this respirator, to try to calm someone down and say, look, I hear what you're feeling, but this is kind of the situation that we're in. And I agree, it would be a great thing to study, as Dan said as well.
Okay, another question. What happens if the patient's condition changes and they want to revise their choice? Who will take on this process and disseminate it?
In terms of like their decision on what box they checked on the decision aid?
My guess would be on the decision aid, although Katie, you may want to weigh in on this in terms of MDPOA as well, but yeah, on the decision aid, if they check one box and then the condition changes and they want to revise their choice, how would that have been dealt with?
Yeah, I mean, I think if you had, I think if we operationalize this in Epic, it would be the patient filled out the form, it got uploaded, kind of like our MDPOAs do, and then you incorporate this into the progress notes of daily providers underneath code status and say, here's this patient's wish around decision aid. That requires those notes to be up to date, and that requires the decision aid to be uploaded into our electronic medical record. So I think there would be a way to do that. We just weren't able to do that our first and hopefully only go around.
And I think in that situation, if social work or care management were told by the patient they wanted to make a different choice, it would be us communicating with the provider and having that conversation.
I think another thing to add is, we didn't have any visitors or caregivers who are great advocates for patients. And oftentimes when people are changing their code status in the hospital, it's a lot of times the caregiver coming or the partner saying, he doesn't want to be DNR, he doesn't know what that means, he wants to be full code. So if we don't have those people in the hospital advocating for patients, that's a potential kind of unintended consequence that could lead to us not actually hearing the patient's voice the way it was meant to be.
Thank you. Okay, another comment and question. Balancing patient autonomy with community needs and clinical professionalism is going to become the norm due to lack of resources. How can we start informing the public about difficult decisions?
Yeah, and I saw that comment come through. It's a great comment. And you know that we have some experience in medicine with this, with things like organ transplantation, where we've been dealing with scarcity since it started. And you know, there's often very transparent committees with lots of stakeholder input that do those processes. But it is something we're going to have to learn and get better with. And like Sarguni mentioned, you know, getting stakeholder buy-in, getting buy-in from the leadership, but getting buy-in from the patients and the community as well in these decisions, so that, and some of this I've learned from listening to Matt Wynia talk too, is that you don't want to do these things kind of behind a closed door. If you really have this scarce resource that you're discussing how to allocate, doing that in a transparent way where people's voices are heard is going to cause less harm than another way of doing it, than just us as a hospital making a decision in a hidden way. I mean, this was part of the discomfort around this. You know, we just didn't know how much time we had, and we were under the impression we didn't have much time. And we tried, you know, we had patients involved, but it's important. I think as that becomes more the norm, we are going to have to get better at bringing stakeholders to the table and getting their perspectives.
I agree. I think one thing that struck me was how altruistic patients were being. This was around the time when you were admitting someone and unprompted, people were starting to say, hey, if there's a shortage, give up my ventilator. And it was it was really moving to see that, because it was all over the news, it was all over the media. And so I think, you know, discussing it as a society is critical, but I don't think we should forget how kind people can really be, which is easy to forget these days. But I would always kind of like catch my breath when someone would say that, because I was like, wow, that's so gracious and generous and kind.
And you know, I asked a psychologist friend about this when we were developing it, about people making decisions like this in the heat of the moment. And there was some psychology literature, and I don't know this literature very well, but she cited some data from the Titanic about how it was preferentially the women and children who were on these boats. So at the time, there was this sort of ethic where people were making decisions of sacrificing themselves for other people. And that is a thing. That is a thing inside humans. And how do you talk about that in a way that's not harmful? It's a very interesting thing.
Do you know if anyone has actually implemented the decision aid? You said there were a number of people who downloaded it, but do you know what has come of it?
Yeah, I wish I had the bandwidth to keep better track of that. My impression is lots of hospitals actually implemented versions of it. You know, we've made it available because in Word, you know, for our other tools, we kind of PDF them and copyright them. But this one, we just put it out there and said, here's language we developed, take it and run with it. And I know of at least a few hospitals that have used it in some form. I don't know how much they used it, and I assume they had similar challenges that Sarguni mentioned, of like, who do we give it to and when, and so I don't really know. I wish I knew that better. I wish I had had the ability to study that. That would have been a fascinating thing to know, but I don't.
Katie, what is the status of the MDPOA project now?
We're continuing it. So for every patient that comes into the hospital, the RN care manager is screening for advanced directives and sending in a consult for us. So that's for every patient in the hospital. However, we are prioritizing those units that are at highest risk. So we still have a long way to go. We need more. We just don't have the bandwidth to get them all done, but the numbers are still coming in those high numbers. And I can say that the hospital and the hospital system actually has been implementing a strategy over the next 5 years of how do we get these advanced directives, how do we improve this for our entire system, and I'm a part of that.
Which gets to another comment and question. Decision aids for end-of-life decisions. So that might be an MDPOA, a good old-fashioned living will, a decision aid, whatever. Decision aids for end-of-life decisions is a process over time. Is it fair for patients to use them or need to address them in a crisis?
No. I mean, it's not fair, but then...
Yes or no, right.
I mean, it's not fair, but people get themselves in that situation if they don't have these discussions beforehand.
Yeah.
I mean, this is why we need to do a better job. It was interesting listening to Katie's talk. I was thinking to myself, gosh, maybe we made the wrong decision aid. If they had 303 consults, maybe we needed to make like a little decision aid and video for how do you choose a healthcare agent. But the social workers could have handed that to people and then spent less time in the discussions.
Well, and actually I can tell you that my counterpart in the ED, Angela Kushnut and her team paired up with palliative care, and they actually had a pilot project during COVID where when folks came into the ED, they tried to get the advanced directive completed. And as a result of that, they actually did do some videos for that, which were really great. And actually they did some videos that talked about, as a social worker, how do I have this conversation and walking through the process. But I also think I was so stunned at how many people and consults we were getting on a weekly basis. I thought, my God, we need an advertising. We need a public service announcement during this time to start advertising that if you don't have an advanced directives, get one, and really getting the word out, because you don't think about it. And then COVID hits, you know.
When it gets, and one of the best ways to get the patient's voice into the visit is a good healthcare agent. And I think there are good agents and bad agents. There are agents who really support your wishes, and that's the gold standard. And if you can do that, that's a good thing. And ideally, a well-designed decision tool would help not just the patients, but would also help the clinicians, and shouldn't take more time if it's helpful. If it takes more time, clinicians aren't going to be able to do it, as Sarguni mentioned.
Well, I also think a key issue is making sure that whoever the agent is who is named or appointed knows that they've been named and appointed and has some idea of what that person would want.
Yeah. Yeah. Yeah, no, certainly in the outpatient clinic, I work in the seniors clinic. I tell patients the most important aspect of this is just who speaks for you if you can't speak for yourself, and make sure they know your wishes and are going to respect those.
Right.
That, all these other things are a little bit gravy in my mind. That's the one that's really helpful if you get sick, because you can't predict every future decision and nuance. But if you have someone who can at least talk on your behalf, that's a really good thing.
It's huge. Any other questions that people have? We are just about out of time, but okay. Thank you so much, Katie, Dan, Sarguni. Really appreciate it, and appreciate your speaking with us about this. So very much appreciative of this. Next month, we will be, I believe it's November 12th, we will be having ethics grand rounds on vaccine allocation and all of the thorny issues related to that. So again, thank you very, very much for your presentation and for your questions, everyone. And we'll see you next month.
Thank you.
Thank you. It was fun to revisit and think through this. So thank you.
Good.